webinar. We hope to hopefully share some accurate facts that you can pass on to your patients and your family and friends as well, because we do want everyone to get vaccinated because that's the only way we're going to come out of this pandemic. And so I'll start by introducing our two presenters. I'll start with Kanavila. Kana did all of her schooling from her bachelor's to her medical school to her family medicine residency at UFT, and she now works as an emergency room doctor at the Scarborough Health Network and at Lakeridge Health in Ajax. And then we have Dr. Mayo Ravichandran, who went to Western for medical school and or for Western for medical school and then UFT in Newfoundland for residency. And they are both going to talk to us about some vaccine facts right now. And if you could use the chat function to post any questions, I'll be moderating the chat function and keeping a track of that so I can ask Kana and Mayo some of the questions that you have. And I'll let them start the presentation.
Great, thank you for that introduction. I'm just going to share the screen, so just a moment here. Okay, can everyone see the slides there on the screen? Shivani, you can see them?
Yes, we can.
Perfect. Okay. Okay. So thank you everybody for being here today. We really wanted to do this talk specifically targeted at healthcare workers, especially people in primary care, but any healthcare worker, because we find that there's a lot of misinformation in the community about vaccines. And we know that a lot of our patients look to our medical people, including their family doctors and specialists, and even any community health worker for medical information about the pandemic and about vaccines. So we hope that we can impart some of our knowledge from working in the front lines in the vaccine clinics that you can then translate onto your patients and help them with their vaccine confidence. So just an overview of today's talk. We're going to talk about the 4 Health Canada approved COVID-19 vaccines. We're going to talk about the vaccination rollout, and then we're going to go on to just talking about specific patient populations and considerations when it comes to the COVID-19 vaccine. And at the very end, we are going to let you know about a very exciting pop-up vaccination clinic that we are running through the Scarborough Health Network, specifically targeted at the Ctma community. And at the end, hopefully we'll be able to answer some questions that you might have. So for disclosures, I have no disclosures, no conflicts to disclose. This is an event that we sort of volunteered to sign up for, and I'm not getting any compensation from any of the pharmaceutical companies or the hospitals. So just a quick COVID-19 update. This week we surpassed 1 million cases of COVID-19 in Canada. There's been over 23,000 deaths in Canada and over 2.8 million deaths worldwide. So we know the burden of the disease. Particularly when it comes to the 3rd wave that we're in right now, there is a major increase in variants of concern. The 3 ones that we see in Canada are the B117, the South African, and the Brazil strains. The B117 makes up most of the variants of concern at the moment. And I think this week it was reported that it's over 60% of the patients who test positive are the B117. These new variants of concern are more contagious and they're more rapidly transmissible. We've seen that they can be up to 70% more infectious and therefore driving our numbers up faster than it was in the first 2 waves. Currently, what we're seeing in hospitals is that the patients are sicker, They're younger, and these are the patients that are being admitted to hospital and the ICU. And we're heading towards, right now, our hospitals and ICUs are becoming over capacity. And right now we have the highest number of ICU admits in all of the 3 waves. We're at 497 out of the 583 ICU beds occupied in Ontario. And we're moving towards an ICU triaging system, which basically means that, similar to what we've read about in Italy, where when we run out of critical care beds and critical care staff, we're going to have to choose which patient gets that bed and which patient is going to die. And then we're also seeing that the one good thing about this is that we're seeing less elderly and long-term care patients hospitalized with COVID-19, and that seems to be directly related to the fact that most of our long-term care residents have been vaccinated with at least two of the vaccines, at least one of the vaccines, but a lot of them have been vaccinated with both doses of the vaccine. So with respect to the COVID-19 vaccination, where are we? We've given over 650 million doses globally around the world. And if we look at some of the big countries that have been vaccinating, Israel is in the lead, where they vaccinated over 60% of their population. The United Kingdom, about 46%, the USA, 30%, and Canada, about 17%. So we're going to spend a little bit of time on this slide. It reviews the 4 Health Canada approved vaccines. So there's a lot of political stuff, but the good thing is that Canada did make really good choices in their vaccine choices when we prepaid for the vaccines, even during the vaccines going through clinical trials. So 5 out of the 7 vaccines that we prepaid for, and we prepaid for 414 million doses of the various vaccines, and 5 out of the 7 that we prepaid for are actually doing quite well with respect to safety and efficacy. So our vaccine choices were really good, even though our supply chain and distribution has been a challenge. So if we look at the vaccines that have been approved so far, the first one that was approved in December was the Pfizer vaccine. And as you know, it's the mRNA vaccine that's given us 2 doses. And if we look at the clinical trial data, the trial data quotes that it's about 95% efficacy when it's looked at 7 days after the second dose. And it's the efficacy, it's really important to understand what efficacy means. So efficacy means that if you take the patients who got both doses of the Pfizer vaccine and 7 days later, 95% of them have been protected against the COVID-19 infection, and only 5% of them had symptoms of infection. So they didn't have severe disease or been hospitalized, but 5 out of 100 people got a mild COVID infection, and 95% didn't get any. If you look at, so that's the trial data. If you look at the real world data for Pfizer, still pretty good. After a single dose, 3 weeks after the first dose, it's about 72% efficacy and 86% after 2 doses. So pretty close to the trial data, but real world data as we're sort of looking at different factors, because the original clinical trials didn't include people who might have been immunocompromised and people with other chronic medical illnesses and other things. So real world data gives us a better representation of how efficacious these vaccines are. If you look at Moderna, the trial data quoted 94% efficacy 2 weeks after the second dose, and similarly, it's against PCR positive infection. That means they had one symptom and then got tested after they got the 2 doses, and 94% of them were protected from COVID-19, and only about 6% got symptomatic disease. And then we look at AstraZeneca, where there's been a lot of controversy over this vaccine, and I'm going to go over some specific slides that look at that. But just as a summary, it's a 2-dose viral vector vaccine, and the original trial data actually didn't show as good efficacy, 63% efficacy after the second dose against against infection. But the real world data actually is a lot more promising. In UK and Scotland and a lot of countries in Europe and India, there's millions of doses that have been distributed with AstraZeneca, and it actually showed that it's 82% efficacy after the second dose when it's given 12 weeks after the first dose, which is why there was that data for delaying the second dose, because it actually seemed to give you better protection when you delay the second dose. And then even in adults who are older, over 70, it still gave pretty good 73% protection against infection. The fourth vaccine that was approved by Health Canada is the Janssen one. It's a single dose viral vector vaccine, and similar to AstraZeneca, the trial data showed 66% overall efficacy against infection, and at least 85 against severe disease, efficacy against severe disease. We still don't have the Janssen in Canada yet, although it's been approved. We're still waiting for that to be distributed and supplied to us. The fifth vaccine that's been submitted for Health Canada approval is Sinovac, and it's showing really good, promising efficacy, about 89% in the clinical trials. And so that may be the fifth vaccine that's coming to Canada as well. And feel free to pop in any questions or comments as we're going through the slides in the chat. Shivani, you're going to keep an eye on that, and that way we can address any questions as we're going. So when you look at some real world data, so what's happened, we know what happened in the clinical trials, but what's happening on the ground in different countries that have actually been giving vaccines to their populations. So one important thing that the trials didn't study that we are now seeing in the real world is vaccines actually do reduce asymptomatic infection. So that is a big deal, because a lot of us who are vaccinated were worried whether we're still passing it on to other people without symptoms, and it does reduce that by up to 70% in some of the studies, the real world data. So that's a good thing. It has good coverage in people over 80. So there was some question over the efficacy of the vaccines in people who are over 80, who, similar to other vaccines, don't produce a very good immune response as they get older. But the good thing about these vaccines is it seems even in the elderly, they do get a very good immune response, especially after the second dose. So we find that after the first dose, the very elderly and frail may not mount as good of a immune response, but definitely after the second dose, they get very good coverage against COVID-19 infection. We know that immunity starts about 14 days after the first dose, and it's not 90% after the first dose. It's sort of an incremental immunity. So, so it is important to remember that just because it's been 2 weeks after a single dose of the vaccine doesn't mean that you're 100% protected. The first dose provides about 70 to 80% protection, usually after the 1 month mark. The mRNA vaccines seem to have good coverage of the variants, including the B.1.1.7. And in fact, the latest AstraZeneca trial data has also shown it has good coverage against the B.1.1.7. And that's the info coming out of the UK and Scotland studies. When you look at long-term care, which is the first sort of cohort of people that we've vaccinated with both, a lot of it with both doses, and we vaccinated the healthcare workers as well as the long-term care residents, it's shown 80% reduction of COVID-19 infection after the first dose of the mRNA vaccines. In both residents and healthcare workers, and even it's just 14 days after the first dose, which is amazing. And even in Ontario, we like in the emerge in the front lines, in the first 2 waves, we saw every single day many patients coming through by EMS from nursing homes and long-term care, really sick with COVID. And in these two, in the third wave right now, after we vaccinated these residents, we are not seeing them come to hospital. And I don't think I've seen a long-term care patient come to hospital in a couple of months with COVID-19. If you look at Israel, so Israel is the country that we're looking to because They are the leader in mass vaccination. We've seen really great data. They were using the Pfizer vaccine, and they were able to immunize a very large proportion, more than 60% of their population in a very short period of time. And it's been over a month since they were able to do that. So we're able to see sort of post-vaccine how people are doing. So at the 14 to 21 day mark, the Pfizer vaccine prevented more than 60% of severe disease. At the almost 1 month mark, more than 80% of severe disease, and 7 days after the second dose, which is past the 1 month, more than 90% of severe disease. So very, very close to the efficacy of the clinical trials, that these vaccines are preventing hospitalization and death just with the vaccine alone. So let's talk about vaccine side effects. So the most common side effects are similar to any other vaccine: local pain, swelling, redness, headache, fever, myalgia, and fatigue. So very similar. If you look at sort of the flu vaccine and the Shingrix vaccine, I would say the vaccine side effects of the COVID-19 vaccine kind of fall sort of in between the side effects of those two. And typically the side effects may last between 24 to 48 hours. If they're really bothered by it, they can take some Tylenol, ice it, rest, but usually doesn't last beyond the 2 days. One of the things that was originally quoted and brought of concern in the mRNA vaccines was the incidence of Bell's palsy post-vaccine. But if you look at the data, so in the clinical trials, the Pfizer vaccine had 3 out of 20,000 of the participants that developed Bell's palsy, whereas Moderna had 4 out of the 15 participants develop Bell's palsy. But if you look at the general population, it's about 1 in 10,000. So if you look at the raw stats and the numbers there, it really isn't any different from the general population, and thus it really shouldn't be a concern. So let's talk about the current most controversial vaccine, the AstraZeneca vaccine. So the AstraZeneca vaccine is a 2-dose vaccine given anywhere between 4 to 12 weeks apart. The studies show that it's about 73% effective against infection after 1 month after the first dose, which is actually at the 1 month point, in some of the studies, more effective with a single dose than the Pfizer vaccine, because the Pfizer vaccine is more effective after the second dose, but this even with the single dose is still quite effective after the first dose. It's 94% effective against hospitalization 1 month after the first dose, and that's based on Scotland, where most of their population was vaccinated with the AstraZeneca. And some of the other pros about it is that it's easy to store. So it can be in the fridge for up to 5 months. And so we can give it at pharmacies and primary care clinics very, very easily, versus the Moderna and the Pfizer vaccine has to be in freezer and thawed. And with the Pfizer, we only have 5 hours after it's thawed to be distributed. Otherwise, it goes to waste. And then the flexible timing for the second dose. So even the data has shown that even prolonging the second dose might actually work better for efficacy than giving it after 4 weeks. So what's the issue? So basically what happened is that there were a few cases that were found in Europe where some people developed some blood clots a couple of weeks after receiving the AstraZeneca vaccine. So when we look at this data, we need to understand what that actually means. So if you look at the overall thrombotic events, so if you look at like DVT, PEs, and all types of clots, the incidence of these thrombotic events following AstraZeneca vaccine and the general population is actually no different at all. But there is a small signal that was picked up in a very rare kind of blood clot that may have a biological plausibility with the AstraZeneca vaccine. And so it's now been termed vaccine-induced prothrombotic immune thrombocytopenia, or VIPID, as an adverse event to the AstraZeneca vaccine. So the important part of this particular event is that they're blood clots that have 2 important features. They occur 4 to 20 days after vaccination. And they're also associated with low platelets or thrombocytopenia. And VIPIT can cause blood clots in different parts of the body, but the main thing that we see is that it can result in something called cerebral venous sinus thrombosis, or CVST. And it's actually not more common in people who have had blood clots before, or have a family history of blood clots, or even have low platelets or are pregnant. So none of these are contraindications, and I know patients will come and ask you this, so it's really important to understand. None of these are actually contraindications of getting the AstraZeneca vaccine, nor are they at, if you had a previous blood clot, you are not at increased risk of getting VIPIT. So the VIPIT incidence it's quoted anywhere between 1 in 100,000, or actually that says 10,000, but it's actually 100,000. Sorry, there's a typo there. So it's 1 in 100,000 to 1 in 1 million, based on which country that you're looking at in Europe, because Scotland and UK actually didn't find those signals there. So it was only in a couple of the countries that it was given out and that they noticed these signals. And particularly in those countries, there were 10 deaths related to VIPIT, although no causal link has been actually proven. And it was 25 out of 20 million patients that developed this. And it's usually within 14 days of the vaccine, and these signals were only found in women under 55. So that's where the NACI guidelines came about, because Health Canada and NACI are super conservative when it comes to safety, especially when we don't have all the data. So just to be on the safe side and err on the side of caution, we basically decided that, or NACI decided that patients over the age of 55 are eligible for getting the AstraZeneca vaccine, because there's no increased risk of blood clots of any type in this age group. And people under 55, since we have an alternative, they can get the other vaccines that are available instead until we get more data. It's possible that in the future, once we have more people vaccinated and we analyze the data further, that this may not even be a risk. But for now, to err on the side of caution, this is sort of what the guidelines state. So, and what's important to note when patients ask about blood clots and the vaccines is that COVID-19 infection in and of itself is very high risk of blood clots. So, it's important to acknowledge that, that 30 to 70% of COVID-19 patients in the ICU develop deep vein thrombosis, and 25% of COVID-19 patients in the ICU develop pulmonary embolisms. So those are really important things to let your patients know, because if your patients are high risk of COVID-19 infection, then or high risk of getting severe infection if they have risk factors, then they really should get any vaccine that's available to them, because their risk of getting very sick, getting a blood clot with COVID-19 infection, is much, much higher than any of the vaccines offered at the moment.
Hi, can I just have a quick question?
Yeah.
Is thrombocytopenia a risk for VIPIT?
So in the data and in the guidelines, thrombocytopenia is actually not a risk for VIPIT. So it's not a contraindication. But that's a great question. So you're also going to get patients who already had the AstraZeneca vaccine and then now are starting to freak out because they're worried that they're going to get this very rare and serious complication. So here's how you would cancel these patients. So if it's been more than 20 days since their vaccination and they develop a headache or other symptoms and they're worried, there's no cause for concern. If it's been less than 20 days since their AstraZeneca vaccination, then you tell them to monitor for the 20 days and seek immediate medical attention if they develop any of these symptoms. So shortness of breath, chest pain, leg swelling, persistent abdominal pain, sudden onset of a severe or persistent worsening headache or blurred vision, and skin bruising that could indicate low platelets, other than the local site that they got vaccinated, where they may have a local reaction or a bruise on their skin. Okay, so the variants. So we know that the vaccines are actually quite good at covering the variants, including the one that's dominant at the moment, which is the B117. And we just don't know how effective they are with the South African strain, because we don't luckily, we don't really have too many cases of that here in Canada. The early preliminary data does show that the Janssen vaccine does have some effectiveness against the South African strain, but again, we don't have head-to-head comparisons, and we don't have proper clinical studies on these new variants that came out after the clinical trial was in place. So more data on that will be evolving as time progresses and the variants spread. So let's talk about the Ontario vaccine schedule. So I'm not going to read the numbers out to you, but this is sort of just to give you a general understanding of sort of, because we're sort of getting weekly or bi-weekly, not bi-weekly, but weekly or every other week deliveries of the different vaccines at different times. So, you know, a lot of our distribution and mass vaccination sites and numbers and appointment bookings are based on, you know, the supply and how it's distributed. And we're trying to sort of now pivot to distributing more vaccines to the hotspot areas, to areas where there's a higher COVID-19 burden and more patients admitted into hospital, because we do know there's a huge difference in different public health units and different populations and demographics with respect to complications and how and the COVID-19 numbers. So hopefully we're gonna, and that's starting to be reflected with these new criteria for hotspots and sort of lowering the age numbers based on hotspots. So for example, we know that York is going into age 45 because it's a hotspot, and a lot of places have gone to 50 plus, especially those areas like Toronto and Scarborough and some other areas that have a high COVID-19 burden. We're trying to pivot more vaccinations toward those heavily affected areas. So if we look at the 3 phases of the vaccine rollout, the first phase, which we completed from December to March, was long-term care retirement homes, frontline healthcare workers, patients who are 80 plus, and Indigenous populations. Phase 2, which is what we're currently in, is sort of age-based, so every 5-year increments as we're going down the age ranking, and sort of high-risk, at-risk medical conditions. Other healthcare workers in the community, first responders, essential workers, and then sort of going into high-risk communities and targeting communities that have a high COVID-19 burden. And then after the summer, we'll be going into sort of the steady state of the rest of the adults and the second doses for the COVID-19 vaccines. So the other thing that recently came into effect is, as you may notice, the change in the second dosing. So after, I think, mid-March, we shifted our dosing schedule to extending the second dose of the COVID-19 vaccine. So most people who got their vaccine after March 10th, their second dose was delayed by 4 months. And the reason behind this is basically for health equity. We want to get everyone vaccinated, all Canadians, by July. So in order to do that, and the only way to do this based on our vaccine supply, is to delay the second dose. And there's been a lot of data, real world data, showing that even with the first dose, we have quite good efficacy in preventing severe disease and hospitalization. So, you know, it's safe to do so. And we're actually trying to sort of have exceptions for that second dosing delay in high risk people. So patients in long-term care retirement homes, organ transplant recipients, chemotherapy patients, biologic immunotherapy patients, and First Nations in isolated communities are all going to be able to get their second dose within the trial period. But the rest of the population will have to wait a little bit longer. What's also important to note, if there is any adverse events, it's important that you direct your patients towards reporting that. And it can, if you sort of Google the adverse events following immunization, you'll get the PDF form and you can help your patients fill it. You can also there's an online version and it's reportable to public health. And if there's any sort of reaction that's happened within 3 months of giving the vaccine, it is important that you direct your patients to report it, because that's how we can collect the data for safety. So with that, how can you help your patients improve vaccine confidence? So what we know is that despite Dr. Google and Facebook and Instagram MD, and all the social media out there, and the misinformation on the news, we know that patients look to their healthcare providers for medical information, and that includes information about COVID-19, and that includes information about vaccination. So, you do have a huge role to play in helping your patients understand the burden of COVID-19, and give them comfort about the getting the COVID-19 vaccine, and helping them to improve vaccine confidence. Um, it's important that you understand and address the concern for that individual. So if someone was pregnant, then go through the data for pregnant people. If someone was high risk and had diabetes or heart disease, or immunocompromised, then explain to them what getting COVID-19 could do to them or their family members. So you have to sort of individualize the way you counsel patients on the vaccines, because that is what people are going to relate to. Use simple data and simple numbers, because otherwise it just gets very overwhelming for them. There are sort of ethnic differences. We know that, for example, South Asians, for many reasons, seem to be more at risk of getting severe complications from COVID-19, as an example. So, make sure you highlight that difference. And then the bottom line is that the vaccines are safe, they're effective, they reduce transmission, and they prevent severe infection, hospitalization, and death from COVID-19 by almost 100%. So efficacy aside, the whole point of vaccinating everybody is to prevent severe infection, hospitalization, and death. And all 4 vaccines have been proven to be almost 100% at doing that. So you can, with confidence, counsel your patients on that. And hopefully that will help improve the vaccine uptake. So with that, if there's any questions in the chat, I can quickly address it, and then Dr. Ravi is going to take over and talk about some specific patient populations and go through the COVID-19 pre-vaccine questionnaire with you as well.
Anna, can
So
you
at the end,
unshare your screen? I'll pop mine in.
Okay,
um,
I'm going to stop sharing here.
so at the end, we're going to have an opportunity for people to unmute to ask questions. And until then, we ask you to please type them in the chat.
Okay, just wanted to make sure. Does everyone see the COVAX pre-vaccine questionnaire?
Yeah.
Yeah. Okay. Kenna, did you want to do are there any questions in the chat that you wanted to address, or should I just keep going?
Let me have a quick look and see.
No questions yet.
Okay. All right. So at this time, we're just going to go quickly over the pre-vaccine questionnaire. So it's important that we all understand it, because especially as we start doing vaccinations in the clinic, or if you end up vaccinating in one of the mass vaccination centers, these questions will come up, and it's important to understand why they're being asked and how to answer the questions to the patients, and also to how to account for it on the questionnaire itself. So some of the topics we'll address is severe anaphylaxis, known allergies to polyethylene glycol, immunocompromised, blood thinners, bleeding disorders, or any other vaccines in the last 14 days, pregnancy, breastfeeding, and age concerns. So this is what the questionnaire will look like. Obviously, it's on a tablet, so it'll be electronic. But these 2 questions right at the top, highlighted in red, because this is one of the few things that actually prevents or contraindication for a vaccine on that day. So if the patient has COVID symptoms on that day, we ask them to delay their vaccine until the symptoms have resolved. Often what we do is we just book them for another date and do that on the spot so that they don't end up missing the vaccine, or we don't end up losing patients to follow up. The second thing is severe allergic reactions to previous dose of COVID vaccine. So patients who have had the first dose had a severe reaction, and we clarify that they mean a severe anaphylactic reaction and not, some people have some flushing, some people have some itchiness that resolves within the 15 minutes that they're being monitored at the clinic. Those ones we allow them to go. But what we often do is, if there is some question or concern, we have them stay for up to 30 minutes, maybe longer if you want to. But that's a judgment call on the day of. But beyond that, we don't really have to do anything to prevent a vaccine on that day. And if you're doing this in your office and say, whether it's the Janssen or the AstraZeneca vaccine, you can do the same thing. You can have patients waiting in the waiting room just to make sure that they're doing okay before they go home. And I'm sure many of you do this for flu shots and things like that, if you've ever had any issues in the past. So the next thing, so this is the third contraindication, which is any other vaccines in the last 14 days. This is to do with the theoretical risk of a hypersensitivity reaction to any vaccines. So we often ask patients to, again, rebook for a new date if they report a, say, a flu shot or their Shingrix or tetanus. We ask them to just book for a new date. And a lot of it is theoretical risk, and it's not fully clear if this is an actual problem. But rather than take the risk, this is one of those things that in the vaccine centers we often get them to come back on a different date. So these questions in blue, and so I'll address the ones in blue. We have a couple slides on. These are important questions to ask, and it was earlier on in the vaccine rollout, we had a different approach to it, and we've started to change it as we get more information. Whether pregnant patients can get the vaccine or breastfeeding women can get the vaccine, and I'll address that later. So these are the special considerations that we have to consider when we're giving the vaccine. So the first one that we can address is pregnancy. So there is obviously very limited data on pregnancy and the COVID vaccine for obvious reasons. These studies did not include pregnant patients, although there were patients who got pregnant during the study without any complications. And the way we address this, and especially now as we've had more information and we've seen the consequences to pregnant women with COVID, we've started to advise patients to get the vaccine. But the way I have the discussion is I often clearly tell them that there is no studies looking specifically at pregnant women. We don't have data telling us whether it's as a randomized controlled trial to tell us whether it's safe or not. But that being said, we have now real world data where pregnant women have had the vaccine and have had no complications. And we have real world data where we've had patients, pregnant women who end up getting COVID and end up with increased risk of complications, including preterm labor, hospitalizations, and ICU admissions, especially in the third trimester. There's been increased risk for pregnant women. So considering that, our recommendation now is to get the vaccine as long as the patient understands the reasons for it and the evidence for or against getting the vaccine. So again, a summary from the SOGC about how to have this discussion and how to counsel women on how to decide whether to get the vaccine or not. And there's the obvious risks. So the healthcare workers or patients who have high risk exposure in the community, with the frontline workers, teachers, grocery store workers, where you're constantly being exposed to people with COVID. When your risk is high, the risk of COVID is obviously much higher than a theoretical concern regarding the vaccine that hasn't been studied in pregnant women. So in those cases, we strongly recommend women to get the vaccine. And then there is the other risk factors of what your medical risk factors. So these are women who have risks that predispose them to worse outcomes from COVID. So that includes weight, diabetes, blood pressure, respiratory issues, cardiac issues, smoking history, women over the age of 35 who are pregnant, or third trimester of pregnancy. So this third trimester of pregnancy it's a pretty big deal, because especially at this point where we're starting to see the COVID, the variants coming in, where even women and men who are obviously not pregnant are getting higher rates of admission to the to ICU. I think now with in the third trimester, we have to take this very seriously, and we have to make sure that we have these discussions clearly and concisely with our patients. So the next consideration is breastfeeding. So again, there is no data to support COVID-19 vaccines in breastfeeding women and for their infants. But again, just looking at the way that these vaccines work and the theoretical risks that could be associated with it, there is no theoretical risk associated with especially with the mRNA vaccines. And so as a result of that, the recommendation is still to get the vaccine, even if you're breastfeeding. And the next point is that with these vaccines, the immunity is often passed, like with a lot of immunity, is passed through the breast milk to the infants. So again, another reason why we're supporting the use of the vaccine in breastfeeding women as well. And the third consideration, this one is a little bit more complicated and has a few more layers to it, are the immunocompromised individuals who are seeking out your guidance on whether to get the vaccine or not. So there's the basic principle of the fact that they're immunocompromised. So that means they're at higher risk of COVID. But the reason for their immunocompromised state is also matters. And often the concern is that if they're taking immunosuppressive medications, that it will blunt the response from the vaccine, and they may not get the full immunity that you're expecting. So in these cases, the reality is that any kind of immunity is better than none, and especially in immunocompromised patients. So patients who are on chemotherapy, on immunotherapy, endocrine therapy, radiation therapy, or any kind of targeted therapy, the recommendation is go ahead and get the vaccine. There are more complicated treatments that is beyond my level as well, but in these cases, often we ask for recommendation from the oncologist on whether they should get it now, whether to delay it. And often the reality is that there's very few indications to delay a vaccine in these circumstances, because again, the risk from COVID for these patients is incredibly high. And we want to get any type of immunity into them as quickly as possible. And whether the delay happens or not, I would get the oncologist's opinion. And anytime I've seen patients in the vaccine clinics who come in, they often bring letters or they just tell us verbally that they had the discussion with their oncologist and they would like to go ahead. And that's really all we require to give them the vaccine. But again, mainly because the only risk is that we may have a false sense of security that the vaccine worked if for some reason the medication that they're taking is going to fully blunt the immune response from the vaccine. But beyond that, it's any kind of immunity is better than none, and it'll only protect the patients. So again, this is just kind of considering the rheumatologic conditions. This again is it's a little bit complex, but let me go to the next slide. So in terms of the most common medications that we see is methotrexate. The recommendation is that we hold the methotrexate 1 to 2 days prior to the vaccine and 7 days after the vaccine. But again, the reality is that if a patient comes into the vaccine clinic without having held the methotrexate, we give the shot, because there is no purpose to delay that vaccine for a theoretical concern about immunosuppression. And what I usually tell them is that they can hold the methotrexate, but have a conversation with their rheumatologist or the doctor that prescribes the methotrexate to discuss whether they should continue to hold it for 7 days or continue. Because again, the reality is a lot of these medications are there for a purpose, and they're being administered on the schedule that they are for a purpose. So there is a risk. We have to weigh the risk of holding the medication and the side effects and the effects of that versus allowing them to continue on the medication and giving them the vaccine, knowing that it may have a blunted response. Again, these are a lot of these medications I'm not going to get into because these aren't medications that I use all the time. So some of you may be even more familiar than I am. So I would follow the guidelines as stated in terms of what the American College of Rheumatology. But I would also have a discussion with the patient's rheumatologist, or have the patient speak to the rheumatologist before holding or continuing these medications. Because it varies. I think it will vary from patient to patient, but these are the general guidelines from the American College of Rheumatology. And finally, so you may have likely heard of the Tamil Community Pop-Up Clinic that we organized with SHN and collaboration with Scarborough Convention Center. And fortunately, it's happening tomorrow, and it booked up within hours of us opening it up, which again showed the need for a clinic like this, because working in the Scarborough vaccine clinics, we saw especially initially, now I think it's improved quite a bit. Initially, we weren't seeing populations that were representative of Scarborough's population. And the question was whether if we had a culturally specific vaccine clinic, not just for the Tamil population, but for the Black community and for other South Asian communities and maybe even Asian communities, whether there will be an increased turnout. So with this initial one, we had a small number of vaccines due to supply, and we did book up quickly. But the reason I wanted to still highlight this is because now is the time to get your patients to also book in with the scarvaccine.ca or any one of the Toronto public locations, because now that there is a little bit more awareness and people are talking about it, this might be the time to get people to go and book their appointments, even though they weren't able to book it here. We're going to look into whether we can do a few more of these if the supply allows us, and if the hospital is on board. But until then, I think the Centennial and Centenary locations are there's always spots coming up. So I think it'll be a good time to vaccinate there. And that's it.
And that's just a slide that I put up. It's a great resource. It's a Canadian resource partnered with Health Canada and Public Health, where you can find a lot of updated information on that's relevant for healthcare workers. There's like patient handouts on the different vaccines, the vaccine schedules, the adverse events reporting form, lots of different and updates as it's coming. Sort of they're updating it quite frequently. So I think it's a great resource as healthcare providers for us to use. So I just put a little slide on that.
And finally, just to summarize, and there is I'm going to see if we can send out a Dropbox link that SHN has actually developed with some community partners with language-specific resources for the COVID vaccine, with FAQs and other information pamphlets. And they're not, for some reason, they haven't advertised it all that well, but I had told them that I would pass it on to all of our family doctors in the community, because I think this will be very helpful as an information source. So I'll see if we can maybe email it out with the link to this talk as well. So in summary, the third wave is rising rapidly, and from day to day we're seeing how much it's gone up and how overwhelmed the hospitals are becoming. And it's shocking how even after our efforts to vaccinate the nursing homes and retirement homes, where we were seeing the most patients coming in during the first two waves, Now we're seeing our ICUs overwhelmed with younger patients, and that's clearly a result of the variants or the community just getting fatigued, and they're just not following the guidelines. Whatever the reason is, it's right now we're at a point where we really only have two options, and one is shutting things down and isolating and masking and encouraging those types of behaviors. And two is to get everyone vaccinated as quickly as we can, with the hope that that will slow down the pandemic. And we've seen it in other countries. I think the U.S., despite how terrible their first two, or I guess they had a third wave as well, how terrible everything was there, with the vaccine efforts ramping up, the numbers have dropped significantly. I think UK has seen similar outcomes, and Israel has seen similar outcomes. So I think that this is our path to normalization of what we've been going through. But so yeah, so I think we need to really push as a healthcare team to get our community vaccinated. And overall, vaccines are very safe, very effective in preventing severe disease and hospitalization. And I think anytime someone keeps bringing up the numbers with AstraZeneca and Johnson & Johnson and comparing it to Pfizer and Moderna, where the people are getting caught up with the 90, 95 versus 60, I think what we have to keep highlighting is the hospitalization and death, because that's all of the vaccines are doing a great job of preventing those things. And that's really all we care about in the end. If patients get a minor or even a severe cold out of COVID because they got the AstraZeneca instead of the Pfizer, that's not really going to make a difference in terms of their long-term outcomes. So I think we need to keep highlighting that. And that's it. So we can open it up for questions. I think Dr. Sandakumar had a few questions.
Mayo, do you want to unshare your screen? Maybe we can,
Yeah.
So everybody can unmute and you can turn your videos on if you'd like. And we'd love to hear your feedback. Hopefully this was useful for your patients, for you to be able to translate some of this information to your patients.
Yes, it's really useful. Thank you very much. I'm Shantakumar from the family physician from Mississauga. I have a few questions. One of them, the variant we are talking about, now they talk about Brazilian variant, which is killing in thousands and, but any of these vaccines were used there, and now it is in Canada. The latest news yesterday in Vancouver, they already have this Brazilian variants. And what do we have, or we have anything for that? And the other one is 4 months gap. Is it evidence based? I mean, the immunity, the studies are all like 4 weeks, 6 weeks, and then they all of a sudden they came up with this 4-month thing. Is there any evidence base for that? And that's number two. And what else? And the other one, the transplant patients, can they have like a renal transplant? And then the blood thinner story, I mean, a lot of patients are on aspirin and Plavix. Do they have to stop that? The cardiac patients, what do they do? And then the immunosuppressant, the renal transplant patient, what are they eligible? Maybe Mayuran sort of on your list, like rheumatoid and all that. And so renal transplant, because I have a patient today and he went to the clinic and they send him back, go get the note from the family doctor. I mean, I can't tell. I mean, he's on the transplant medication, I mean, anti-immunosuppressants and all that. So these are all practical stuff we are facing every day. So if you can address some of those, I will appreciate that. Thank you.
Yeah. So I'll try and tackle some, and maybe Myron can tackle a few. With respect to the dosing intervals, so the data that Canada used to justify the dosing intervals is based on the European data. So most of Europe, since end of December, extended their second dose of all the vaccines to 12 weeks. So, and the data showed that even with a single dose, about at the 1 month point, they have pretty good efficacy. So about 70% at least in the different vaccines for protection. So with Canada, they used that 12 weeks and extended it to 16 weeks, assuming it's sort of similar. And that was the reasoning behind that with respect to efficacy data. So it's about health equity. So it's if you get both doses, you're over 90%. If you get a single dose, you're somewhere between 70 to 80% if you look at the 3 vaccines that we have. And that's good enough for a population reduction. Because if everybody gets vaccinated by July, it really doesn't matter if it was 70% or 90%, if everyone is protected. So that was the reasoning behind it. But yes, there is data from Europe that the delay is still safe and it's about 70 to 80% efficacious. So that's the interval, the data behind the intervals. The renal transplant patient, so renal transplant recipients are actually eligible even if they're on immunosuppressants. I'm not sure why he was sent back, but we are vaccinating renal patients. And in fact, renal patients are part of the exception for the dosing interval, and they actually get their second dose at the 21 to 28 day point. Now, when they come in, we're actually booking their second dose right away. So they're 100% eligible for the vaccine. Mayo, do you want to? There was a couple other questions.
Do they have
Sure.
to stop their medication, any transplant medication for a few days or
No.
anything? No.
No.
Okay.
No, so they shouldn't be stopping their medication. And I think in terms of questions of whether it's going to be a blunted response or not, I think they're obviously on their immunosuppressive medications for a reason. And I think there will be never any recommendation that we stop that in order to give the vaccine, because I think the outcomes from that would be much more severe. So again, I think that's the main reason we're also shortening the interval to 21 days for them, because we want to get them immunized. Even if there's a blunted response, it's okay. We can get them their second shot in within 21 days. In terms of the blood thinners, there is no contraindications. And I should have addressed that in the questionnaire. So there is no contraindications. We just documented for the reason that there could be some bruising and bleeding after the vaccine. Other than that, there is no contraindications to blood thinners or bleeding disorders in the past. And I don't know I don't remember what your other question was, your third one.
Plavix and aspirin, that's antiplatelet agents.
That's all fine. They can continue those medications and still get the vaccine.
The Novax, coumarin, warfarin.
No
So
problem.
it's all fine. Yeah. No, it's all fine. We just documented for the reason that that we know if there is some bleeding afterwards, what the cause was, or if there's some significant swelling, bruising afterwards, what the cause was. But there is no contraindication based on the blood thinners or antiplatelets or any anticoagulation.
And my last question is NSAIDs. NSAID use, that's a big question. People are calling, should they have to not take aspirin, not Advil? I think there were some reaction, and there was there's on the social media, there was one person, husband gave Voltaren and the wife died for the, inflammatory reaction. So, what is the story there? NSAIDs and the vaccine.
So you're talking specifically with the vaccine?
Yeah.
Or because initially there was some concerns, or I guess rumors about NSAIDs and COVID itself, and then there was some other evidence supporting the use of NSAID as almost to treat COVID. So there is no contraindication with NSAID use with the vaccine that I know of. There's been no evidence in support of not using NSAIDs. The only thing is they've said that NSAIDs can blunt the immune response. So they've said don't take it unnecessarily. So I think some people, including me, so after I got my vaccine, I just took an Advil right afterwards, just so that I could keep working. But I think they're saying don't do that. Don't take it as a preventative. If you do have symptoms, headache, or a lot of pain, then take it. It's fine. But there is no contraindication based on evidence. I don't know if Canna has anything else. There may have been some story, but I didn't know about that.
Yeah, so there's been no issues with NSAIDs taken after the vaccine. Like Mayuran said, it's there's a theoretical, like I'm sure in your family practice, you know, there was a study that came out that said if you give Tylenol or Advil before you give a routine immunization, it could blunt the immune response. So that's really the only thing that, and it's theoretical, it hasn't really been proven in real world data. So what we tell patients is, you know, don't take the Advil or Tylenol before your vaccine. But if you have a fever or your arm is really sore, then go ahead and take some Tylenol. It's not a big deal. And I don't think NSAIDs is similar, so it's not a huge deal if they end up taking some Advil.
And I think Dr.
Thank you.
Rajendra
Thank
had
you.
a question. Dr. Rajendra had a question.
Are you still on mute,
Hi,
Dr. Rajendra?
I'm Rajendra. I know Shivani and I know Mayo, and when I met Hannah, this is the first time I'm seeing you video. My question again is piggybacking on Santakumar's question, efficacy. Moderna and Pfizer, 3 and 4 weeks interval according to the monograms, and basically Health Canada. If you look at Health Canada, they have said 3 and 4 weeks, but NACI has said it's 12 weeks. After the first dose, the efficacy is 70% roughly, you know, give and take. But after the second dose, it goes to 90. We do not know how long this 70% is going to last. Nobody, I don't know whether these are random. I think, in my own opinion, it's a random for 16 weeks. So most probably nobody has done any controlled trials on these things. It's because of the non-availability of vaccines. They have done this. And I think it's basically is quite a lot of people are giving different views. I'm not sure whether it's a clinical decision or administrative decision. So I am quite sort of caught up in, has anybody known any studies which has shown that even after you give 4 months, there's an increase in the immunological response after 16 weeks. It's only an arbitrary decision by Europe, 12 weeks, and Canada has taken 16 weeks.
So, I mean, we're basing it on, it's being based on the European data, the 12 weeks. Canada extended it to 16 weeks, not because of science, but because of health equity. It was the only way to get everybody immunized by the summer, is if that extension was to 16 weeks. We know that the first dose gives you at least a few months of immunity for, you know, up to 70 to 80% based on the real world data in Europe. And so that's the numbers that we're going by. And we just kind of look at it as, you know, if you had two 70-year-olds living together, married, living together, to a husband and wife, and only if we were doing the 3-week interval, only one of them could get the vaccine, and the other one had to wait 2 months for his, or but that one other person got their 2 vaccines, but the other person was unvaccinated and had to wait, versus the same couple, we could give both of them their first dose at the same time, and they would be up to 80% protected until their second dose comes in. That's kind of how the decision was made. I mean, we didn't make the decision, NACI made the decision, but that's sort of the reasoning behind it. And if everybody gets vaccinated by July, then the 70% doesn't matter. Like, the comparing 70 and 90 really doesn't matter, because everyone's going to be protected. The incidence, the case numbers and the incidence would be so low, like it was last summer, where we had very little cases in the hospital, that people could start doing normal things again. So it's not perfect. If we had enough vaccines, then we would do it as the trial interval, because it's based on real, true science. But when it comes to practicality and real world, this is sort of the limitations that we have to deal with. And so that's sort of what the reasoning behind it. I don't know if it's right or wrong, but I think that's how it's been justified, and that's what we're aiming for. And, you know, we have been able to push up, like June's vaccine amount that was originally agreed upon is actually more than what we had. So we're getting 9 million doses, and it was actually less that we were supposed to get. So it's possible that we are going to be able to, if everybody gets vaccinated and we go through the phases very quickly, we may be able to vaccinate the second dose even sooner. And it really depends on the supply. But you're right, we don't have randomized control trials to prove that the 12-week or 16-week interval is in fact as efficacious as it's sort of as we presume, but we're going on the data and of other countries that have done sort of similar things.
And obviously, for liability reasons, neither Pfizer or Moderna is going to support going to the 4-month interval. They'll never come out and say that, even if it is for real world applications, even if it is effective. And for public health reasons, I don't think we have much of a choice. And I think it will be effective. I think the choice to vaccinate people and give them 70% immunity for 80% of the population versus 100% immunity for 20% of the population for the next couple of months, and then in June start to get more, I think it will save us a lot of hospitalizations and deaths. And especially at a time like this where things are just skyrocketing, I think it's more important to get at least that one shot into as many people as possible, rather than trying to get everyone or fewer people fully vaccinated in that 3-week period.
And then I think
sure there will be antibody studies going on now. They can prove that. They're monitoring the antibodies. So.
And I think we'll get some data from places like Israel and UK, or UK, I think, has been doing that one shot. And I think within the next month or so, we should be getting data from them that should tell us if we're way off or not. And hopefully we're not. But I think we should hear from the UK studies soon.
And I think Dr. Logan had a question.
Yes, I just have a couple of questions, and if somebody else asking, and I could ask only one. So what about the prednisone? Somebody is on the long-term prednisone. Do we need to stop before the vaccine or after the vaccine, anything like that?
No, I think I would look at it the same way as any one of the other immunosuppressive medications. If they're on it for a reason that is obviously medically necessary, and they have to be if they're on it, I would continue the prednisone without interruption. If they're on really high doses of prednisone, then I would have a discussion with the rheumatologist or endocrinologist that's prescribing it. But if it's low dose maintenance, then I would continue it.
Okay.
The other thing, sorry, Dr. Logan, is they may also be eligible to get the second dose earlier for whatever reason they're on the high dose prednisone. So if they are severely immunocompromised, they may be eligible to get that second dose, and that way, despite being on the prednisone, the second dose will allow them to have a better immune response.
Is the atrial fibrillation, if they are not on any antiplatelet therapy, are they high risk for the blood clots after the vaccine?
Not any more than anyone else.
Normal
so
population?
the vaccine is not going to increase their risk of blood clots because they're an AFib. I think if they're they don't have to change their medication, so they don't need to go on antiplatelet or anticoagulation or anything prior to getting the vaccine.
Couple of patients of mine, and without they have already conducted with the COVID patients, and they already had a vaccine, and one person ended up in the hospital, not due to the vaccine, but probably the COVID, and the other person is nothing changed, but has a mild symptoms. And is that anything like they could differentiate by doing the test, whether it's is that an infection or is it a vaccine effect?
I think they would look at it based on the timeline between the exposure and the infection. So I think these are where the history comes into play. So I've been making some phone calls to COVID positive patients, and I've already had a couple cases like that where they tested positive for COVID after getting the vaccine, like a week after getting the vaccine. And the reality is that COVID symptoms often come up to 14 days after exposure. So we often have we're often chalking up the infection post, or the symptoms post vaccine, if it's exposure was within the last 14 days, to the exposure, not to the vaccine. And again, so far there has been no severe hospitalizations or severe reactions resulting in hospitalizations from the vaccine, except for anaphylaxis. Other than that, symptoms relating to the vaccine have been very mild for the most part. I actually don't know that there's any evidence supporting that the vaccines are causing any hospitalizations. Again, except for anaphylaxis.
Is nobody else, and can I ask some more question?
Sure.
Okay, so is that when someone has a COVID positive, is that ACE and ARB and the SGLT2? Anything we need to hold on after the positive test?
Not that we've seen. I know initially there was some question about ACE inhibitors with COVID-19 infection, but I think the latest update from cardiology is that they shouldn't be stopping their ACE inhibitors. It doesn't make a difference.
Is the SGLT2 any evidence whether
No.
ketoacidosis, anything increase or anything like that? And
No.
okay.
Not any different
And
COVID-19 versus any other sepsis.
okay.
I have a question.
And if I hear that people who had even after 2 doses of vaccine, and people are getting the COVID-19 infection, how do they detect that? Is that a PCR antibodies? I thought is when we have a vaccine and we will develop antibodies, no?
So we do the nasopharyngeal swab, and vaccinated people, if you swab them like we test everybody, they shouldn't be positive. So it's the same way that we test anybody else. So a vaccinated person.
Okay.
Yeah.
So the vaccination is not going to affect the PCR testing.
Correct.
No.
So I have a question here. Can a patient with pancytopenia, so neutropenia and thrombocytopenia, get the COVID vaccine?
Yes, so based on the recommendation about, this is probably specific to the AstraZeneca, with the rare risk of thrombocytopenia. Anybody with low platelets or pancytopenia, it doesn't seem like that's a risk factor for VIPIT. So the CVST related to, or thought to be related to the AstraZeneca vaccine. So it's not part of the contraindications.
Okay. And would you recommend one vaccine over another for a high-risk individual who is eligible for both?
I don't think I would, like, based on the data that we see, they're all safe. And the whole point of the vaccines is to prevent severe infection and hospitalization. So personally, I wouldn't choose one over the other. Like, my mom was eligible for AstraZeneca, so she got the AstraZeneca vaccine. I got the Pfizer vaccine because that's the first one that was available to me as a healthcare worker. It's a personal choice, but with respect to safety and efficacy and the outcome that we're looking for, which is preventing severe infection and hospitalization and death, they're all equal. So for me, it would be any one of them. Myron, I don't know if you want to.
No, I have the same thoughts. I don't think we have anything to support us choosing one over the other at this time. I think the question was more like specific to specific medical conditions, if we should be considering one over the other. And again, I don't think there is any evidence to tell us to choose one over the other at this time. There might be something in the future.
Especially because there actually hasn't been head-to-head randomized controlled trials actually comparing the different vaccines, right? Because the efficacy that comes out is, the way they did it is different in each of the trials. So with like Pfizer, they asked for patients to have one symptom, and if they did, then they would get PCR tested. But for AstraZeneca and some of the other vaccines, they actually did PCR testing on all their, so even patients who didn't have symptoms, they were able to pick up. So that's probably what drove down the efficacy. And you have to remember, the clinical trials of the different vaccines were done at different times. So the AstraZeneca and Janssen trials were done when the variants started emerging, and it was done in the fall and winter where COVID-19 prevalence was higher. Versus if you look at Pfizer and Moderna, they did it in the summertime the trials where the incidence and the prevalence of COVID-19 infection itself was very low. So by virtue of just the season, their efficacy would have been better. So there's no randomized control trial that's head to head of these vaccines, and that's why you have to be really careful. I know everybody looks at like, oh, well, it's 94, 95%, that must be better than the other ones. But really, when you look at real world data, they're actually very similar.
Okay, I have one question about, where do we draw the line on the anaphylaxis? I mean, people have kids carrying peanut allergy, they are carrying EpiPen, and, I mean, people, even environmental allergies can give anaphylaxis. So, I mean, what are we going to do with them, and where do we draw the lines when they are EpiPen carriers with a history of anaphylaxis?
So that is not a contraindication. So even if they have anaphylaxis to other things like peanuts or environmental things, that's not a contraindication to the vaccine. The only thing that has been said to be a contraindication is people who have known anaphylaxis to polyethylene glycol. And that's one of those, it's a rare thing that honestly, I've never heard of anyone having anaphylaxis to polyethylene glycol. So the only thing I do is if at the vaccine clinic, if someone tells me that they have severe anaphylaxis to really anything, I would talk to them about staying longer. So instead of the 15 minutes of monitoring, I say 30 minutes of monitoring. But beyond that, it's not a contraindication for the vaccine. And I think so far we haven't seen any in any of the any countries where we've seen people have anaphylaxis to the COVID vaccine when they've had anaphylaxis to some other random thing.
So the polyethylene glycol is a component of the vaccines only, or where else we find that?
So we see it. So obviously we use it in the laxative, so PEG 3350, but also in a lot of cosmetics. So this is why it's very unlikely that people would have the anaphylaxis to this because it's used so broadly and widely. But that's how I usually tell them about it, because most people haven't even heard of it, right? So they wouldn't even know to tell you if they have the allergy. So I just tell them that it's found in a lot of cosmetic products, laxatives, and if they've never had any severe anaphylaxis to those things, then we give it to them. And if they, and again, this is where I err on the side of caution there when they have a history of anaphylaxis to something else, and especially if they don't know what it is, because we see that in the emerge a lot where people have anaphylaxis and they never really find out what caused it, then it's just safer to just hold them for a little bit longer just to monitor. But I wouldn't not give them the vaccine as a result of that.
So PEG is found in like moisturizers, sunscreens, shampoo. So even if you've never taken a laxative, you probably consume PEG. It's like additives in medications. So you don't need a colonoscopy or have taken a laxative to, I think you would know. I have a patient who's actually allergic and it was in the dentist's like whatever they use to like clean the teeth. And that's how she found out she was anaphylactic to it. So I think most people would figure out they were allergic to PEG at this point in their lives.
So this PEG is for all vaccines or just for one Pfizer vaccine, or is it?
I think it's Pfizer and Moderna. I think it's one of the components of stabilizing the mRNA, not for AstraZeneca or Johnson & Johnson.
Okay, thank you.
Any other questions?
It was great, great information. Thank you, both of you. Yeah, thank you for taking time.
Thank you.
Can I ask a question?
Yes.
Both of thank Kana and Mayo, you're working in the emergency rooms, one at Ajax, one at Scarborough hospitals, I think. Do you see a differential number of patients on the ethnic group, high incidence of COVID? As a statistical, we have not done a statistical study, but I hear that certain pockets of population in Scarborough, certain pockets of population in Markham, where mostly immigrants live, there's increased incidence of COVID. And is it due to ethnicity or is it due to environmental factors or both?
I can try to answer that. So I think there's a lot of factors involved in that. It's definitely concentrated in Scarborough and Brampton, Markham. So the areas where there is more South Asians, but there's also a higher concentration of people who work more frontline type of jobs. So I think for many reasons, South Asians and people who work frontline jobs are living in conditions where they're living in close proximity with larger families, and those reasons are why we're seeing higher incidence in the South Asian community. But there's also higher incidence of diabetes and hypertension and heart disease. So when they do get it, they end up getting much sicker than the general population. A lot of people in other neighborhoods in Toronto have the option of taking time off or of working from home. And I think if you work these frontline or factory type of jobs where you have to be there in person, you don't have that option. Either you have COVID and you're more likely to go into work and spread it, or you're more likely to bring it back and spread it to everyone in your house. And the number of times that I've tried to call back a family, especially like a Tamil family, and seen that they tell me that their whole family is COVID positive, it's common, and really that's the reality of it. And I think initially there was some news reports that criticized the South Asian community for the big weddings, and honestly I agree with that criticism. I don't think we should be doing those large gatherings and weddings, but I don't think that was the reason for the spread. I think those initial news reports ignored the fact that it's the reality of how a lot of South Asians live and work that puts them at that higher risk.
Other than the environmental factors, if there are endemic cause within the South Asian community who are more prone to COVID, I
don't know if they're more prone to COVID, but I think they're more prone to getting sick from COVID.
Right.
I think everyone else, especially because of the higher risk of or higher incidence of diabetes and hypertension, all that stuff. Yeah. So those things that we often see in people who end up getting admitted to ICU is higher incidence in South Asians.
Yeah, majority of our very sick people in the ICU have the metabolic syndrome, hypertension, diabetes, and hyperlipidemia and heart disease. That seems to be a very common theme. And they're young, they're not old. They're 40s and 50s, many of them. And in Scarborough, we admitted a lot of very, very, very sick Tamil patients who were not that old. So, yeah.
Any other questions? Okay, well, thank you, Kanan Mayo, for doing this informative presentation. I think it was really helpful for everyone here today.
Thank you for being here.
Thank you.